Brief disclosure. Kids who present with conduct disorders represent a serious problem. Anne-Marie alluded to that earlier. They tend to display conduct problems as a cluster, not as individual behavior problems. And what we see is that they tend to display overt, in-your-face types of problems like fighting, as well as more covert, kind of sneaky types of things like vandalism or stealing. And the kids who are very far along in developmental pathways for this particular problem tend to be very versatile in terms of presenting with symptoms of both these overt and covert types of conduct problems. In the DSM-5, of course, oppositional defiant disorder and conduct disorder are the two diagnoses that are most relevant here. And various epidemiological studies suggest that in terms of referrals to children's outpatient mental health services, that these kids account for more than 50% of such referrals. When you look at broader general population epidemiological studies, children with conduct problems account for somewhere between 5 to 10 or even 11%, depending on the study, of children in the general population. And children who present with conduct problems typically present with a variety of other types of behavior problems as well. ADHD, of course, is highly comorbid. They often have substance use problems and a variety of learning difficulties as well. What I'm going to do today is to give you an overview of evidence-based approaches that are based on family interventions for dealing with children who present with conduct problems prior to the age of, say, 6 or 7 or so. In order to do that, what I want to first do is spend a little bit of time giving you some background about the developmental pathways with which conduct problems develop and the particular familial context in which they seem to arise as well. Then what I'm going to do is talk about a few basic approaches to parent management training. And one of the things that I want to emphasize is you'll see how many of the most commonly used PMT programs in North America, or in fact internationally, are derived from the work of a couple of very important individuals. I'm going to spend most of the time, though, this morning talking about what the empirical evidence says about what we know about the effects of these particular programs, not only in terms of outcomes, but also in terms of mechanisms, and also in terms of whether or not they're generalizably applicable to various subgroups of children or to specific subtypes of conduct problems. Then I'm going to wrap up by talking about what we don't really know yet at this point and some implications for practitioners. Now, we've known now for 25, 30 years or so that children develop conduct problems in various ways, and they come about this through various developmental pathways. The one that's of most relevance to us this morning is the so-called early starter pathway. And as the name implies, these are kids who start to begin to manifest their conduct problems during a very early age, typically during preschool, no later than first grade or so. They tend to engage in both overt and covert types of conduct problem behaviors, and there's a very high degree of continuity, not only into adolescence, but into adulthood as well. And in fact, even back when we started doing some of our early work, we knew that in terms of epidemiological data, that if you have a child who's engaging in high levels of conduct problems in multiple settings between the ages of 5 and 8, that there's a greater than 50% chance that that particular youth is going to demonstrate very significant and severe conduct problems during adolescence. Not too surprisingly, because of this high degree of continuity, these individuals tend to have a poor prognosis. Again, not only in adolescence, but in adulthood as well, and I'll have a bit more to say about that in a couple minutes. This is just a sort of prototypical developmental progression for an early starter type of pathway. And the way to look at this particular chart is from the behaviors progress from younger to older. They progress from less serious to more serious. To a certain extent, they reflect behaviors that begin to occur in the home setting and then gradually expand to the outer community. So you see there, disobedience at home appears earlier than disobedience at school. We also see it with covert types of behaviors too. In the third category, aggression, you see that stealing at home begins then, and then later on it begins to generalize to stealing outside the home. So maybe initially stealing money from mom's wallet, then later on shoplifting at the 7-Eleven or something like that. The other way to look at this chart is to think about that in the earlier stages, there are far more children engaging in those less serious types of behaviors than there are engaging in the more serious ones at the bottom. So that's the good news. The bad news is that as for those kids who actually are going to still be engaging in serious conduct problems later on, is that they haven't left behind the old conduct problems that they started with. So in other words, by the time these kids get into this so-called delinquent phase of conduct problems, they're doing not just those behaviors, but they're continuing to do a lot of the early oppositional types of behaviors they started out with, but now they're doing it in sort of a teenage mode. So in general, the idea is that we're going from a fairly large number of kids who are engaging in fairly low-level but still difficult behavior problems to gradually engaging in much more serious ones. And so this is one example of why, as Anne Marie was alluding to in her talk, a focus on early intervention and prevention can be very important, because if we can intervene with these less serious behaviors earlier on, we may then not have to deal with things like fire setting, vandalism, theft, and so on as these kids get older. Okay, so those are the types of conduct problems that we're talking about, but how is it that these kids get started on this early starter pathway? Basically what we know is that there are multiple ways, or environmental context, biological context, and so on, that influence the development of conduct problems. And in fact, no two individual kids with conduct problems will necessarily have exactly the same pattern of risk and protective factors that influence the development of their conduct problems. Having said that, though, if you had to come up with sort of a recipe of things that you could think about and that the evidence base shows that increases the likelihood that a child will embark on this early starter pathway, here's some of them. First of all, we'd have this child born into a very dangerous and violent neighborhood, probably to a young adolescent mother who herself might have a history of antisocial behavior. The father, who may or may not be present, also would have a history of antisocial behavior. During pregnancy, mom may have ingested various substances, alcohol, perhaps leading to fetal alcohol syndrome, or in fact smoking cigarettes, which has been implicated as a risk factor not only for later conduct problems in terms of prenatal exposure to nicotine, but also for ADHD as well. Once the child is born, then basically there will be problems with the attachment relationship in the first year of life, and then during the sort of toddler period, almost certainly the development of what Gerald Patterson has referred to as a coercive cycle of interaction. And I'm going to explain that quite a bit in just a couple of minutes, so I'll hold on that. As the child moves into the point where he or she is ready to begin kindergarten, a couple things are going on. First of all, compared to other kids from more middle-class environments, these kids tend to come to school very poorly prepared for the educational and academic demands. There's very little reading at home going on to the kids. If they're watching TV, it's not educational. It's really more as a babysitting type of device. And so when they go into kindergarten or even to preschool, they sort of have a double whammy going on, because first of all, academically, they're not very well prepared. And secondly, they're not very well prepared behaviorally or socially. Because of this coercive cycle of interaction, they basically have learned that the way you get what you want at home is to be very aggressive, controlling, etc. So you try that with your teacher, and it doesn't work very well. And in fact, what we often see is during the first month, literally, sometimes even the first weeks of school, these kids find themselves being sent down to the principal's office. They're in an out-of-room timeout, and so on and so forth, which is causing not only problems in terms of their reputation with the teacher and with other kids, but it's also preventing them from acquiring the academic skills that they actually need to a greater degree than the other kids. So from the get-go, these are kids who are basically in trouble with the teacher. They're being actively rejected by their peers because you don't want to sit next to this kid or hang out with this kid, either because they're going to get you into trouble or because they're going to hurt you. And this degree of rejection starts very early on in the school process, and it continues progressively throughout the school experience. So by the time these kids are sort of finishing up elementary school, ready to move on to middle school or junior high, what we see is that many of them are also displaying signs of clinical depression. And Deborah Capaldi, who's done a lot of research in this area, suggests that it's a function both of the academic failure these kids are experiencing, as well as the social and behavioral failure, the peer rejection, the difficulties at home, getting along with family there, difficulties with getting along with other authority figures, and so on. Once these kids get into middle school, there's a dramatic escalation both in the frequency and the severity of the types of conduct problems they're doing. It has to do with some structural changes that go on with middle schools where there are lots of different opportunities for transitions and the like. It's also the case where this is where the kids really come into contact with the so-called deviant peer group. So typically in North America, kids are in a small elementary school. There may be relatively few numbers of kids who are behavior problems in a particular classroom. A number of these smaller elementary schools feed into a large middle school or junior high school, and at that point, you have sort of a critical mass of kids with these behavior problems, and they seem to be magnetized. They seem to connect with each other. And Tom DeShawn and other people have shown that there are a lot of really important learning processes that go on here with these kids during this particular period. So, for example, there's a lot of direct reinforcement for inappropriate behavior. I'm going and hanging out with my best friend, and he says, "What'd you do last weekend?" And so I say, "Oh, I went to this party, and I got really drunk, and I threw up all over myself, and it was really funny." And this guy, instead of sort of looking at me askance or disapprovingly, as most other kids would do, said, "Oh, that's really cool. I'm going to try that this weekend as well. Let me tell you what I did." So they get into these war stories. In addition, there's a lot of direct instruction that goes on during middle school around these inappropriate behaviors. And so I might go up to Dave Reitman and say, "Dave, let's go hang out tonight. If you pick me up in your car, I'll show you how I hotwire cars down in the parking lot." And Dave says, "That's cool. I'll show you about how there's a liquor store that's really easy to shoplift in." So there's a lot of direct instruction in deviant behavior. And for that reason, and because of the opportunities to sort of get into stuff in middle school because of all the transitions, we seem to see this real escalation. By the time these kids then are at full-blown adolescence, they're not only engaging in serious delinquent behavior, but they're not doing well in school continuously. They're often starting to drop out now. Many of these kids are engaged in early substance use and heavy substance use, and we know from lots of data that the earlier individuals start using alcohol and drugs, the more likely it is to develop into a serious problem. These kids are also at risk for early sexual activity, unprotected sex, multiple partners, etc. And not surprisingly, as I mentioned, because of this increase in depressive symptoms, they're at risk for comorbid psychiatric disorders as well. As adults, not surprisingly, they're more likely to engage in criminal activity. That's fairly self-evident. They're much more likely to be diagnosed as antisocial personality disorder, again, a fairly obvious one. But what's less obvious is the fact that, in general, these early starting kids with conduct problems as adults seem to be at risk for pretty much every single DSM diagnostic category you can think of. So the risk broadens tremendously in adulthood, and it's not just limited to antisocial behavior. These kids also, again, because of the increased likelihood of dropping out of high school, or if they stayed in, of having very poor grades and so on, don't tend to have as successful an adjustment to the world of work as other kids. Not surprisingly, they continue to have relationship difficulties that might relate to marriages or long-term relationships of various sorts. And in addition, they're at increased risk for early death. Again, you might say, well, that should be fairly obvious. These are kids who are engaging in violent activity, many of them, and so a lot of these kids are probably dying from violence, and this is true. It's also true that these kids are at risk of dying from cancer, from cardiovascular problems, from diabetes and so on at a higher rate than the general population. No one knows exactly why that is. It probably ultimately will have something to do with chronic and early stress going on and affecting a variety of organ systems. So the bottom line here is that this early starter pathway is a very dangerous and insidious one. From an economic perspective, it's also a significant problem. This is some data from Mark Cohen and Alex Piquero. Cohen's an economist, Piquero's a criminologist. It's based on data from about 28,000 youth in Pittsburgh. And basically what they concluded is that if you can divert just one of these kids on this early starter pathway from a life of crime, you can save society somewhere between $3 and $5.5 million. Now, the big spread there, the $3 to $5.5 million, is a function of whether, in addition to preventing criminal activity, which gets you to the $3 million, can you also increase the likelihood that this kid will stay in high school and also prevent significant substance use. And if you can do those things, which of course are both highly associated with this early starting conduct problem pathway, then the savings are actually closer to $5.5 million. This is a very important argument for early intervention and prevention. Aside from the important moral and I think ethical reasons for why we want to help kids early on, when you're pitching prevention to politicians and policymakers, this economic argument is often a very important one. Now, back to these kids when they're little. One of the things that we have known for a long time is that noncompliance or disobedience to authority figures like parents and teachers seems to be a keystone behavior. And we call it a keystone behavior for a number of reasons. First of all, it's a major concern and reason for referral. It appears very early in the developmental sequence. You saw on that chart that it's one of the first conduct problems to appear. It seems to be highly correlated not only with overt, in-your-face types of behavior problems, but also the more covert ones. And it's also associated with a variety of DSM diagnostic categories in addition to ODD and conduct disorder. And what we found in our work many years ago, and other people have since replicated it, is that if you can successfully treat the noncompliance, then what we find is that other conduct problem behaviors will often decrease on their own without being a direct focus of treatment. Okay, and so it represents a certain efficiency, if you will, in intervention. There's been a lot of research around the different parenting practices that are associated with conduct problems. Patty Chamberlain wrote a great review article a number of years ago, and basically kids with conduct problems tend to experience inconsistent discipline, irritable or explosive discipline where it's very erratic and unpredictable, low supervision and involvement of the parents, particularly as they get older, and finally, very rigid or inflexible discipline. And these are usually not either-or types of things, but sort of a real mix of unpredictability for these kids. Many years ago, Robert Waller, who was one of the key figures in terms of delineating some of these family processes, talked about this whole idea of the unpredictability of day-to-day living that seems to sort of characterize what goes on with these kids in the context of the family. I mentioned earlier Jerry Patterson's idea of the coercive cycle, and based on my clinical experience, and certainly what the research literature would suggest, this coercive cycle is present in virtually all kids who have this early starting pattern of conduct problems. The coercive cycle is really interesting because it really comes out of very normal parent-child interactions that virtually any parent of a 2 or 3-year-old will experience at one time or another. It goes something like this. I come home, I see my 3-year-old, and he's got toys all over the living room. I'm totally exhausted, and so I give some sort of instruction. Patrick, I need for you to pick up your toys. Patrick may not want to do that. And this is very typical because particularly 2 to 3-year-olds, they're testing the limits. This is a way they learn eventually self-control and so on. And he goes, no. But in addition, he throws in something that Jerry Patterson calls a high rate aversive behavior. So he doesn't just say no, he says no, or he might start to whine, for example, or he might throw a temper tantrum, or he might even be aggressive. Those are all what Patterson calls high rate aversive behaviors. Okay, if this happens once or twice or a dozen times, it's not a big deal. But when it happens hundreds of times over the course of months or maybe even years, it potentially becomes a problem. Because here's what happens. Patrick, I need you to pick up your toys. No, Daddy, I don't want to do that. I've come home from work, I'm tired, I really don't want to put up with this. And so what do? I say, all right, damn it, I'll do it myself. So I pick up the toys. Now again, if this happens over and over again, what Patrick is learning is that if there's something he doesn't want to do, he can kind of get out of it, at least with his dad, by whining. What I learn over time is that if my kid is whining, I can get him to stop by not asking him to do anything. Okay, again, we've all been there. Anybody who's a parent here and says they've never done this, I'm really doubting your veracity. What happens, though, in the coercive cycle is that this goes on for a while. The pattern becomes more firmly entrenched until one point the parent, me, kind of wakes up and says, hey, wait a minute, I'm the dad here. This is a 3-year-old, and he's calling the shots. And so in Patterson's model, what happens is I start to increase the ante, and I emit my own high-rate aversive behavior when I give Patrick an instruction. Patrick, either you pick up those toys or it could be any of a variety of things. I'm going to spank you, I'm going to do this, I'm going to do that, or whatever, but it's a threat. Patrick goes, whoa, he's never talked to me like that before, and so he does it. And again, if this happens every once in a while, no big deal. But this starts to happen on a consistent basis, and so now I basically learn that the only way I can get my child to do anything is not to ask nicely, but to be kind of the bad guy, to really sort of throw in my own sort of threat. It works for a while, but eventually Patrick goes, you know, the whining's not working anymore. Maybe if I throw a temper tantrum, I can get out of stuff. And sure enough, he can. And so that works for a while. And then eventually, I up the ante even more. He ups the ante. And so now we're at a point where there's a lot of yelling and screaming from me to him to me, aggression going on from him to me, possibly even from me to him. That's the logical end of this coercive cycle. But it doesn't have to get to that point at all for it to be very, very negative and have very serious negative effects on the family. This is the point where when the family comes in to see me or to see one of you guys, basically the parents are describing a situation where this kid won't do anything a parent asks them to do. And not only that, there's a lot of stuff that goes along with it, the high rate aversive behavior. And so a key goal of intervention with these younger kids is to try to disrupt that coercive cycle, this very insidious thing, and to try to reestablish a more positive relationship. So these are this sort of how it continues to go on and on and on. Okay, there are other family factors that are also associated with conduct problems in addition to different styles of discipline and the coercive cycle. A number of studies have shown that parents of kids with conduct problems often have very maladaptive social cognitive processes going on. So for example, they often have very hostile attribution about their children's behavior. Interestingly enough, many of these kids have the same thing. So whenever the child does something, even if it's accidental, these parents are more likely to assume that the child did this on purpose, okay, not as an accident. And if you assume that the child is always doing these negative things on purpose, then you're more likely to respond in your negative coercive style of interaction. It's also the case that many of these parents have significant problems around their own history of antisocial behavior, which of course can influence the child possibly through some genetic influences, but certainly through modeling and possibly even through direct training. Many of these parents also have problems with substance use, and many of the moms present in a clinical setting with significant levels of depressive symptoms, maybe not at a diagnosable range, but at a very high level. Now, interestingly enough, we often find that at the end of a successful parenting intervention, those depressive symptoms go back into the normal range. So in those particular cases, it seems most likely that the depressive symptoms were a function of just living in a very stressful, chaotic environment with a difficult child. And finally, to use a term Bob Waller coined years ago, many of these families are socially isolated or insular. And what Waller meant by that is that they're often basically in communities where there's very little interaction with other families or with other kids, and so the parents don't really get a good sense of what normative parenting is all about or what normative child behavior is all about. And so they develop their own idiosyncratic ways of parenting these kids and either overreact to their behavior or they underreact and completely ignore the fact that these kids are being very aggressive and disruptive. So given all of these key causal and maintaining factors, maladaptive parenting, coercive parenting, and these other family risk factors, it's a fairly easy leap to then go to say a family-based intervention like parent management training should be a core component of intervention. And what you're going to hear me say today a couple of times is that with younger children, the kids we're talking about today, it may actually be sufficient. It may be all that needs to be done. Whereas with older children, you may need to do additional types of interventions as well. Now, Alan Kasdan laid out sort of some of the basic tenets of PMT a number of years ago. First of all, the principles and the techniques tend to be derived from social learning theory and from operant conditioning for the most part. There is a sort of ABC type of relationship where you're looking at antecedents, the things that precede the particular behavior, and then you see what sort of consequences accrue. And those ideas of this ABC model relate not only to the principles of social learning, but also to the techniques that are derived from them. So say the principle of positive reinforcement leads to emphasizing to the parent the importance of praising appropriate child behavior. PMT tends to be a very active treatment modality. There's a lot of role-playing and demonstration and practice. And to sort of jump ahead a little bit, you'll see from some meta-analytic studies that have been done in just a little while that that active component really does seem to be a key factor in predicting success. And the other point that Kasdan makes about PMT, although I think it's probably ignored a little bit these days, is the importance of integrating assessment in an ongoing basis in terms of how you're doing your treatment. So in addition to doing a good pre-treatment type of assessment, we also need to be looking at issues around modifying our intervention based on ongoing assessments throughout the course of treatment. Okay, I've got this slide up here just to remind me that prevention and health promotion and treatment are really on a continuum, and they kind of glide from one to the other. And I've talked already a little bit about PMT as a treatment, but also as a preventive intervention. And just to sort of simplify it, if you think about it, if this child is diagnosed with ODD and we're doing PMT, then that's a treatment to treat the ODD. But potentially, and hopefully so, it's also a prevention for later conduct disorder as a diagnosis or for delinquent behavior as an adolescent. So the point here is that interventions, early interventions, can be both treatment and they can be preventive as well. Okay, so let's talk a little bit about basic approaches to PMT. Pretty much all of them, with various sort of tweaks, do the same thing in terms of content. Very strong emphasis on developing a positive relationship, using differential attention. I'll talk more about that in a few minutes. Giving clear instructions, and then providing some sort of consequence, whether it's timeout or response cost, etc., for inappropriate child behavior. In delivery, there's a very strong emphasis on a collaborative relationship between the parent and therapist. As I mentioned, very active instructions. You see PMT being administered to individual families as well as small groups. On average, with a clinic-referred family, 10 to 18 sessions, although a fair amount of variability there. Now, there are two pretty much primary approaches to PMT, and just totally coincidentally, they were both developed in Oregon in the 1960s, early 1970s. The two individuals were Connie Hanf and Jerry Patterson. Connie Hanf was based at the Oregon Health Sciences University. She never published a single study on parent management training, but her influence was primarily as a mentor and a trainer to some of the key figures in PMT, and I'll show you that in just a minute. The program that she developed was originally for developmentally handicapped children. And today, there's at least 5 primary versions of her work that have been adapted for kids with conduct problems. So Chuck Cunningham's COPE program, Russ Barkley's Defiant Children, our program, Helping the Noncompliant Child, Carolyn Webster Stratton's Incredible Years, and Sheila Iberick's PCIT are all derived directly from Connie Hanf's original program. And all of these people were trained directly by Connie Hanf as an intern or as a postdoctoral fellow, or in Carolyn Webster Stratton's case, as sort of like a second-generation trainee of Hanf who trained Carolyn. So there's Connie Hanf on the left. There's the various folks who have adapted these programs. Now, the Hanf-based programs, as we'll call them, have a number of common features. They tend to focus on younger kids, 3 to 8 or so. The focus is very much on noncompliance as that keystone behavior. 2-phase program, and again, I'm going to describe that in a little more detail in a few moments. Focus on the parent-child relationship, and they teach 5 core parenting skills. Now, even though there's a lot of similarity among these Hanf-based programs, there's also some differences. So, for example, whether they're taught only to individual families or into a group context, whether or not there are performance criteria for moving from one skill to the next, whether or not the child is actually present in the room during treatment sessions or not, and whether there are booster sessions. So again, all of these derive from the same common ancestor, Connie Hanff. They're all very similar to each other, but there are some differences that are potentially fairly minor. To give you a better flavor for a prototypical Hanff program, let me talk a little bit about the one that I know, which is helping the non-compliant child that my mentor, Rex Forehand, originally developed, and I had the privilege to kind of build on the work that he did, and we sort of have continued to work on that over the years. Again, like all Hanff programs, non-compliance, younger kids, we do have the child in the room with us throughout that period. HNC, as well as these other Hanff programs, focus on a sequence of parenting skills using very active teaching methods. You're down on the floor with the kids, playing a lot, role-playing, practicing, so is the parent, demonstrating different things to them, and so on. And in HNC, progression from one skill to the next is competency-based. In other words, before you go from, say, attending to rewarding, the parent needs to display a certain level of those attends and to avoid directing the child's play. And we have these criteria for each of the 5 skills. In phase 1 of this 2-stage program, the differential attention stage, as I mentioned earlier, the focus is on disrupting that coercive cycle of interaction and developing or reestablishing a more positive relationship between the parent and child. And we get the parent to use 2 positive parenting skills, attending, which is just simply a description of the child's ongoing activity, and what we call rewards, which are really basically are praise statements, labeled praise, in conjunction with planned ignoring. And when you put the positive attention for appropriate behavior together or combine it with planned ignoring, that's differential attention. And what we find is that that usually takes care of most of that high rate aversive behavior that Patterson talks about, and maybe even a little bit of the non-compliance. But you really need that second phase, the compliance training, to really get into dealing directly with the non-compliance. So we have something we call the clear instruction sequence. You teach the parent how to give a clear instruction to the child, to wait a specified period of time. If the child starts to do the behavior, then you have the parent praising the child for that appropriate behavior. If the child doesn't do it, then they give a warning, which is basically repeating the instruction and specifying the consequence, which is timeout. If the child goes ahead and follows the warning, then you praise that. But if they don't follow the warning, then we institute a brief timeout procedure, bringing the child eventually back to the original situation. Once the parent has mastered that and the child's responding well, we do something called standing rules, which are basically things like, if you hit your brother or your sister, you'll automatically go to timeout. So you're dropping out the warning thing there. It's a little more developmentally advanced. Okay, now, PMTO, Parent Management Training Oregon model, developed initially by Jerry Patterson, and then John Reed and Marion Forgach have kind of taken it to another level. Basically, focus on noncompliance, but also aggression, a little bit older age group, 4 to 12-year-olds, and they typically don't include the kids in the context of the treatment. PMTO teaches 5 core parenting skills: positive involvement, skill encouragement, which is positive attention, big emphasis on tangible rewards, problem solving, monitoring, and various discipline procedures. So not just timeout, but also response costs, fines, and chores, which is developmentally appropriate given the higher age range that they work with. This is sort of a head-to-head comparison of HNC and PMTO, not to say one is better than the other, but just to kind of give you a sense of how they are alike and how they may differ a little bit. So PMTO, as I said, has a little bit broader age range. They don't have the kids in the room. There's less of a focus on the parent-child relationship than you would see in the Hanff-based programs. They put a lot of emphasis on tangible reinforcement, which you don't typically see in the Hanff programs, and they don't have performance criteria. A third example that I want to talk about, Triple P, I want to talk about not because the techniques or the procedures are so different, but because it really represents a broad system of intervention. And as you probably know, it was developed by Matt Sanders and his colleagues in Brisbane, Australia. Triple P programs now pretty much cover the waterfront from birth to age 18, but the evaluations of triple P interventions have pretty much been focused on the 2 to 8-year-old age group. And basically the triple P system of intervention ranges from very broad universal strategies like radio spots and tip sheets and public service announcements and things like that to reach everybody in a community, to very, very intensive PMT types of interventions up there at the top of the pyramid. In between, levels 2 and 3 are very brief interventions administered by healthcare professionals in 1 or 2 or up to 4 sessions. But level 4 would be pretty much traditional PMT. Level 5 would be PMT plus adjunctive treatment, say for marital therapy or something like that. Triple P teaches 17 core parenting skills, but they cluster into promoting positive relationships, encouraging desirable behavior, teaching new skills and behaviors, and managing misbehavior. And as you can see there, these are all things that you pretty much see in most other PMT programs as well. Okay, what I'd like to do now is shift gears and talk about what we know about the evidence base for PMT. Over the years, there have been many, many qualitative reviews, but what's interesting is over the last 7 or 8 years, there probably now are close to 20 meta-analytic reviews of some aspect of PMT or another. Some of them focus on outcomes, some of them focus on moderators or mediators, and so we're getting a lot of really good information, and it's really reflecting, I think, the increasing maturity of the science of people who are looking at these particular types of interventions. So unlike some of the scenarios that Anne-Marie was talking about in this research to practice gap issue, this is not a situation where there's not empirical evidence to base a decision on, as you'll see. So to sort of summarize, first of all, in terms of outcomes and generalization, we know that in terms of short-term outcome, sort of post-treatment, that basically effective PMT can be conducted in the clinic setting, it can be conducted in the home, it can be conducted with individual families or with groups, and there's some data to suggest that for some parents, but not all, self-administered approaches can be effective as well. In terms of immediate treatment outcome, a number of meta-analytic studies have shown that in terms of effect sizes, we get medium effect sizes for changes in both parent behavior and parental adjustment. And then for actual changes in child behavior, the effect sizes range from medium to large. In terms of generalization, we see a generalization of positive effects from the clinic to the home setting, which of course is really a key finding, because if all we're doing is changing child behavior and parenting behavior in the clinic setting and then things go back to the way they were at home, we really haven't had much of an impact. But that's not the case. There are dozens of studies now that have shown that transfer of effects to the home setting. Fewer number of studies, but a fair number have shown that parents generalize these strategies to untreated siblings in the family and to untreated behaviors. And so as I mentioned at the beginning of the talk, PMT interventions focusing on noncompliance can also lead to decreases in temper tantrums, whining, and so on and so forth. And now there have been at least 2 studies that I'm aware of, one with HNC, one with Carolyn Webster Stratton's Incredible Years, that have followed kids up for more than 10 years. Her follow-up was 11. Rex Forehand published 1 year ago with a 14-year follow-up. Again, issues around statistical controls and so on, but suggesting that these kids in general are doing reasonably well. Generalization to the school is another issue. There's very limited evidence to suggest that PMT effects will transfer to the child's behavior in the school. You can actually find a few studies that show that, but you can also find an equal number that show no effects, and a very few number of studies that actually show what I call the hydraulic model of child misbehavior, whereas the kid's behavior improves at home, it actually gets a little bit worse at school. Fortunately, that doesn't usually happen, but the take-home message is that if you have a child who's school age, then you need to monitor and assess what's going on in school, and if the problems are there as well, you need to develop a school-based intervention. Don't expect or assume that PMT is going to carry over to the school. 2 primary indicators of social validity. One of them would be consumer satisfaction, and a number of programs have reported high levels of participant satisfaction for periods of a year or more. Others have taken a more rigorous approach and actually looked at whether or not parent and child behavior improved to within the normative range. And again, a number of programs have documented that. In one of the first meta-analyses that was done back in 1996, Serketich and Dumas showed that 17 out of 19 of the treatment groups in that meta-analysis actually dropped below clinical range on at least one of the measures, and in fact 14 of those 19 groups did so on all measures. So that's a pretty impressive set of findings. In terms of control conditions at this point, PMT has been compared to no treatment, to waiting lists, to attention placebo, and more interestingly, to other types of interventions, active interventions, family systems, other forms of PMT. Howard Abakoff and Lori Miller-Brotman in New York just published a study comparing a program out of the UK called the New Forest Parenting Program for kids with ADHD to HNC, which was intended to be the control. It turns out that HNC did equally well with these kids, and in some cases even better around some of the ADHD types of symptoms. PMTO has been compared to available community mental health services, as have a number of the other programs, including Triple P. Another meta-analysis that was done with older kids, 6 to 12-year-olds, showed that PMT had a larger effect size than individual child cognitive behavior therapy with, again, 6 to 12-year-old kids. One of the most interesting meta-analyses came out of some folks at the CDC a few years ago. This is a study by Kaminsky. And what they were interested in looking at was what predicted successful outcomes, whether for parenting or for reducing child conduct problems. And really interesting here, in both child and parenting outcomes, teaching positive parent-child interaction skills was a very strong predictor. Okay, this is important because back in the day, like when I was in graduate school and even beyond, there were some folks arguing that the only thing that was important in PMT was the discipline stuff, and that the positive interaction strategies were kind of just good PR and marketing. The data don't support that at all. It's very important to develop that positive relationship, not only for what it is, but also because it sets the context for parents becoming effective when they do have to use discipline with their kids. In the yellow, it's also the case that for both successful parenting and child outcomes, having the child or having the parent practice with the child during the session was a predictor of outcome. So I mentioned that HNC and some of the other PMT programs do that. And so if you have the choice, the data are suggesting this is a good thing to do. Fidelity is essential. Anne-Marie touched on that as well. The PMTO folks in particular have really done an excellent job of developing ways to assess fidelity and documenting how important it is to successful treatment outcome. We're now at a point where we've moved beyond simple outcome studies of efficacy, and there are now dozens, literally, of dissemination and effectiveness trials. And Triple P, Incredible Years, PCIT, and PMTO have been disseminated internationally, North America, Europe, Australia, Asia. Triple P is actually looking at going into lower income and developing countries and seeing how these interventions can be administered on a national level. PMTO has been administered across Norway for a number of years. Incredible Years is in a whole variety of places. I think Triple P is in more than 20 countries. So PMT in general is very widespread. In terms of cost-benefit types of analyses, the Washington State Institute of Public Policy published a paper a couple years ago where they showed that for every dollar invested in Incredible Years, PCIT, or Triple P, you would get back anywhere from $1.20 to as much as $5.63. So suggesting that all of these interventions are cost-effective in terms of how much it costs to implement and then the resulting cost savings from decreases in mental health service use, etc. But we also know that PMT is not effective for everybody, and in fact, as many as a quarter to a third of families, it doesn't work. And dropout can be high. Rex Forehand published a study ages ago that showed a mean of 28%. I think that's probably still the same. Another meta-analytic study by Reno and McGrath showed that the predictors, first of all, for outcome, successful outcome, and for dropout differ somewhat. The number of X's indicates the strength of the relationship. So you see for predicting outcome, low SES is the strongest predictor, but there are a variety of other things too, like maternal adjustment, level of conduct problems, referral source, etc. Predictors of dropout are not as strong, have not been as strongly identified, and you can see there's not all that much overlap between predicting outcome and dropout. I would say over the last 10 years or so, there's also been a shift in focus to beginning to look at what the mechanisms are of PMT. We know that it works. Now what we need to know is how it works. 50 years ago, almost, 48 years ago, Gordon Paul said it best. The big questions are how and why does an intervention work? He wasn't talking about PMT, and for whom? And those are the types of questions that the field is now turning to look at. Unfortunately, the short answer is we don't really know the answer to a lot of those questions, although we're moving along. So these are questions of mediation, how and why does the treatment work, and also moderation, for whom does this treatment work, for particular subgroups of kids or for particular subtypes of conduct problems. In terms of mediation, Rex Forehand and his colleagues at Vermont just published a really nice review just a couple of months ago, looking at all of the research that's been done where they actually examined whether or not change in parenting behavior mediates change in child outcome in PMT. When you think about it, this is really core to the rationale for doing PMT, right? We've always assumed that by teaching the parent to do better parenting skills, that this will result in improvements in child behavior. It's interesting, Forehand couldn't find any studies on mediation done before 2000, even though there have been literally hundreds of PMT studies up to 2000. He's found 25 studies, more of them focused on prevention than treatment, which is interesting. And only about half of those studies actually support mediation. And then the next part of the slide is showing, depending on the particular parenting skill, you see greater or lesser evidence for mediation. So when you lump them all together, the composite measure, 9 out of 10 of these studies are showing mediation. But then when you get down to monitoring, it's only like 10%. Mediation has been demonstrated more for younger kids under the age of 10 than for the older ones as well. And when you look at the different parenting programs, PMTO has done most of the research, or more research than other programs, documenting the importance of mediation in their particular program. If we turn to moderation, for whom does PMT work? There's much less information, although a meta-analysis that was conducted by Lundahl back in 2006 presented some interesting types of information. And basically what they found was that things like SES, single parent status, low levels of pretreatment conduct problems all predicted poorer outcomes or moderators of poor outcomes, as was group-based PMT as opposed to individual PMT. In their particular meta-analysis, child age wasn't a moderator, which is interesting because it does vary somewhat. And what was most interesting, I think, in this meta-analysis was the work they did around disadvantaged families, because what they found was that for disadvantaged families, economically disadvantaged families, the evidence was pretty clear that they do much better with individual PMT than group PMT, not only in terms of child behavior outcomes, but parent behavioral outcomes as well. And even though it's not significant, you see the same trend for parental adjustments as well. Again, sort of as I've said before, prevention of serious conduct problems may be our best bet. We know that when kids get to be adolescents, these things are much more difficult to treat. There was a meta-analysis a few years ago that was a sort of a meta-analysis of meta-analyses. It was based on 26 reviews and meta-analyses comprising over 1,000 studies. And what they found was that prevention studies that focus on the parents have a much larger effect size than those that are either child-focused or school or community-based. Okay, so we talked about what we know. What are some things we don't know right now? Big questions are about, do we need to develop specific subgroup treatments? Like for single parents, Marian Forgatch has developed one for newly divorced moms. There's been some discussion about developing ones for moms who are clinically depressed. Do we need to develop culturally specific treatments, or do the PMT programs we have now work equally well for non-majority families? Would we be better off to adapt those programs, or would we be better off starting from scratch? The data are unclear at this point, but for most of the studies that report analyses or outcomes separately for whites and African Americans and Latinos and so on, there's not much indication that there's any differential effectiveness. So to date, the evidence suggests that they're comparable in effectiveness. That's not to say that they couldn't be made even more effective for those groups by making some changes, but we're just not quite there yet. One area that has been looked at fairly significantly is looking at comorbidity. And so conduct problems with plus ADHD, that of course has been something Russell Barkley has focused on quite a bit. I mentioned some recent data coming out about HNC. A number of folks with PCIT have looked at comorbid conduct problems and anxiety. But where sort of a lot of the action is coming through now is the comorbidity of conduct problems with so-called callous unemotional traits, or as it's called in the DSM-5, limited prosocial emotions. Basically, Paul Frick has done some very important work in this area, and he suggested that there are at least two subtypes of early starting kids, or childhood onset kids. There's the prototypical primarily impulsive type of kid, which is the one I've been talking about for the most part this morning. And then there's a kid that he called a callous unemotional type. They're engaging in conduct problems, but they also have, again, limited prosocial emotions. They seem to lack remorse and guilt for their behavior. They don't seem to have, they have a minimal or even absent degree of empathy. They're unconcerned about what they do, whether that's school, work, whatever. And they just seem to have a very flat, shallow affect. And Frick and others have documented very clearly that if kids have both conduct problems and CU traits, that basically they're going to engage in more serious conduct problems, they're going to be more extensive, they're more likely to get incarcerated, and so on and so forth. And it's been suggested that these kids don't respond to intervention, including PMT. David Haas and Mark Dadds just published a really good review paper, as has Becky Waller, looking at this. It's really multiple questions, right? First of all, do these kids respond to PMT at all? If they do they respond to the same level that other kids do without CU traits? And does PMT actually decrease CU traits in addition to conduct problems? Well, what Haas found was that, in fact, CU traits are associated with poorer outcomes from PMT. Found that in 9 out of the 11 existing studies. Much more likely to be seen with kids with ODD. But the kids with CU traits do respond to PMT, just not as well or to the same degree. And it's actually specifically related to the phase 2 elements of PMT. In other words, the timeout discipline strategies. There are now 2 randomized controlled trials that also show that CU traits decrease after PMT, in addition to decreases in conduct problems. So that's good news. And it also calls into question, by the way, whether these are really traits or not. In fact, they may be something more like features, which are malleable, which is a much better thing. So in terms of indicated clinical strategies at this point, if you have kids with conduct problems and CU traits, first of all, PMT should still be the basis for treatment. The promotion of warmth and positive engagement and positive rewardment is especially important with these kids, because we have known for years that they have a reward-oriented style of responding to things. And so these early phases of parenting programs are especially important with these kids. It's not that you ignore the discipline, but you really beef up the warmth part of things. A number of people, including myself and colleagues at University of Washington, are interested in looking at some adjunctive components to PMT to see if we can do a better job. So Mark Dadds in Australia is looking at emotional engagement. He's putting a lot of emphasis on reciprocal eye contact. I'm doing some work with Lynn Katz right now where we're developing an intervention or adapting an intervention she developed called emotion coaching to integrate with HNC. So these are things that are all in very early stages of development or evaluation. Some things we don't know and where we need to go. We need to do a better job of developing treatment selection and matching guidelines. We need to do a much better job of elaborating the processes in which we engage families and keep them in interventions. Some of the best work that's being done in that area is Danny Shaw, Tom DeShawn, and so on, who are involved with the family checkup intervention with very young kids. We need to look at ways to enhance treatment outcome and generalization. And I think one of the things that we're going to see a lot of in the next 5 to 10 years is some really interesting ways of incorporating technological advances into PMT design and delivery. A lot of programs are now being delivered on the internet or are being supplemented by the internet. Deb Jones up in Chapel Hill is doing some interesting things, developing smartphone apps for HNC as a way of engaging very socially disadvantaged families and kind of keeping them into the intervention. Finally, I want to close by talking about a few implications for practitioners. First of all, we need to stay on top of the literature. We need to know the problem. We need to know about what we know about conduct problems, about the comorbid conditions, and about the risk and protective factors. And we need to screen and assess broadly for all of those things using evidence-based assessment practices. PMT is always, I think, going to be a core component of treatment with these young kids and with prevention. And as I mentioned at the beginning, it probably in some cases, or in many cases, can be sufficient with the younger kids. We know that PMT is less effective for single parents and for economically disadvantaged families. It's unclear if it's more or less effective with children with more severe conduct problems. There's some data to support either point of view. And it may be more effective when it's administered to individual families rather than in groups. Good news is it seems to be comparable for boys and girls and for majority and minority samples. Multi-component treatments are often going to be necessary with older youth. And so the other types of components that are relevant are child skills training, academics, peer relations, and so on. But even then, PMT is going to be an essential component. So here's just some examples, a few examples of some multi-component interventions that have been designed for older school-age kids. Fidelity is essential, and just like Anne-Marie, I've got Phil Kendall's great quote about flexibility within fidelity. And the idea here is that you do have to make sure that therapists adhere to these evidence-based interventions as they were designed, but it's also probably very important to allow for modification and adaptation for the non-core elements so that an agency or a therapist can make the intervention his or her own. Finally, let me just say for those of you who might be graduate students out there or in the early stages of your research career, two things. One, let clinical experience, both your own experience and that of others, stimulate and inform your research. And I think there's a lot to be gained from parametric analog studies that examine specific components of techniques, like timeout, for example, or planned ignoring. And a great example of this is Mark Roberts at Idaho State, who has done some incredible studies about the parameters of timeout that pretty much tell us as clinicians what are the best ways to do timeout and to make sure that it works as opposed to the 10,000 other ways we could do timeout and it doesn't work. These are studies that can be done with small samples, even with non-clinical samples, and you won't spend the next 10 years of your life doing your master's thesis or your dissertation. Finally, prevention is got to be a key focus. It's important both in terms of just practicality. It's important, I think, morally and ethically, and we now have data to suggest that it is effective. Thank you for your attention and for the work that you do with children and families. So the question is, with 3 and 4-year-olds, can you reliably and validly assess conduct problems? And then part B of the question is the callous and emotional features. So the first part, absolutely you can assess disruptive behaviors accurately and validly in kids that young. And Kate Keenan and Laurie Wachschlag published some very nice studies a number of years ago documenting how reliable and valid ODD as a diagnosis is, for example, in kids as young as 3 and 4. The question about identifying callous unemotional features in young kids is a good one, and in fact it was something we had to answer when we were applying for this grant that we just got to look at emotion coaching in HNC, because our sample will be clinically diagnosed kids with ODD from 3 to 7. And in fact there are some data. Eva Kimonis comes to mind as one person who has identified CU features in these very young kids and has also shown that they are stable over time. Mike Willoughby up in North Carolina is somebody else who's looked at this with very young kids. So there is a body of evidence that's suggesting that's the case. Yeah, so that's a really good point. So she's building off the point that I made that the data don't support generalization of PMT to school setting. And so if you're dealing with an individual child, then the logical solution is to develop an individual school-based intervention. But what do you do if this kid is in an aggressive classroom and in an aggressive, violent neighborhood and so on? And basically, if you were to go in the classroom, I'm extrapolating here, but basically this kid would probably look just pretty much like everybody else in the classroom. And the difficulty there would be there's not much you can do in terms of individual intervention because it's probably just not going to take. And so, what you would be trying to do at a minimum would be some sort of classroom level intervention if the teacher was willing to take you on. And depending on, who your employer is, that might or might not be a possibility. And it's a huge task, but otherwise, trying to set up an individual program for this kid is unfortunately, I think, just not going to work. Other questions? Thank you very much.